Hello, this is Dr. Lewerenz at Longevity Health Institute. Good evening. I hope this finds you well in fall of 2019 here in November, getting to be cold out. So I have listened a little bit of a story I want to share with you about a pattern of patients that I kind of routinely see. I will tell you today's visits of what we went through. But I want to share with you something because there's one common link in these three patients, okay? And people that follow me and subscribe to us out there, you may pick up on this, but I want to share these stories because these, albeit very unique stories, are also very common threads of things that we see here very often. So I'm going to tell you what's going to happen with them and what would be a very common solution. So there's one common thread with each one of these cases. I have three different cases here I saw today, all women, 153, 167, 147. The first one that was 53 years old, her biggest issue was endometriosis. She was having a lot of worry and anxiety, hair loss, decreased sleep, hot flashes were new, and had a lot of worry about endometrial buildup, hormone imbalance, risks of endometrial or uterine cancer, ovarian cancer, breast cancer. Again, she was menopausal, newly menopausal at 53. And here's the interesting part is that we've talked many times about hormone and hormone replacement. She's been with me for years. We've helped her with her Hashimoto's and thyroid conditions, and her gut health and her immunity and her thyroid antibodies have gotten much better. But here at 53, she is struggling with the decision about what to do and why she's got so much anxiety, why she's got hair loss, why she has decreased sleep. She's hot flashing. She's a worrier, she said, which is not innate to her or her norm. She recently saw her OB-GYN that did a ultrasound on her uterus and her endometrial lining, even though she's postmenopausal or menopausal, and not bleeding, she is getting some endometrial buildup. The next patient is a very unfortunate case. I've known her also for a very long time. She's 67, is struggling with lung cancer, and is oxygen dependent mostly. She's also developed in her lung cancer that she's had this subacute mild case of lung cancer, that she's developed an infection in one of her lungs. That's mycoplasma type of infection, very hard to treat and isolate. She's gone through many rounds of antibiotics using intravenous lines for weeks on end, days even, on end over weeks. She can't get rid of this infection. She's wasting essentially. She's losing weight, getting to something we call sarcopenia, which is muscle and weight loss. Now, she was small to begin with. It's at 96 pounds. Now she's down to 93 pounds, getting very frail, okay? And the biggest issue here is with her is that she is weak, tired, on oxygen. They're talking about she doesn't qualify yet for a lung transplant, but is she a case here that they could help with a lung resection? But albeit she's not the healthiest individual, or I should say the strongest individual, when you have sarcopenia or wasting, this is a big, big health risk, okay, regardless of what's going on with you chronically. The third case is a new patient that came here, new to us today from another referral of another patient. She's 47 years old, newly menopausal. She hasn't had a menstrual cycle in over a year. Her biggest issues are fatigue and lumbar pain, and she's gone through, about 2 years ago, a lumbar fusion, and she's had, prior to that, 6 epidural corticosteroid shots for her back pain. She had some relief with her back pain, and but nothing that really lasted very long or was anything substantial. So she lives on Norco, on pain medication, and high-dose Motrin, and she's very fatigued, struggles with fatigue on a daily basis, works, has children, 47 years old, menopausal. She's really struggling in her life with just having a quality of life, but she deals with pain and then this back situation that even with a fusion didn't resolve. And her biggest complaint, her goal, I always say to you, you know me out there, I always say there's two situations here when you come to see us at Longevity Health Institute, whether you see me or my wonderful nurse practitioners or other providers that we bring on board. We're going to solve your goals. What are your goals? And then we're going to have goals, and that's to keep you well and to keep you in a preventative model. Her goals where she has chronic fatigue and then this pain in her back and this inflammation, and her quality of life at 47 at this young age is very, very low, she felt. So what is common? What's the common thread here? I'm going to give you the answer. So I'm not asking kind of a question. It's kind of self-explanatory here. There's a common thread. 53-year-old female, 67-year-old female, 47-year-old female, endometriosis, anxiety, hair loss, lung cancer, sarcopenia, wasting, chronic pain, lumbar, back pain, fatigue, poor quality of life. What's the common thread here? Hormone decline. Their hormones are going to play an essential role in not only helping their goals, but also in creating a wellness preventative model, okay? And I'm going to go through each one of these cases and keep this kind of brief if I can. So the details, obviously because of time being of essence and not to bore you, but I want to educate you a bit and share this with others, okay? There's a common hormone thread here, which is very key. In endometriosis, that's estrogen dominance. This 53-year-old woman has estrogen dominance and has a risk of buildup of endometrial tissue. But in perimenopause, she has had low progesterone. Low progesterone is the first hormone decline in perimenopause going into menopause. You'll lose progesterone first. So yes, she had Hashimoto's and thyroid that we balanced and are working on and is optimal and balanced, and she's pleased. But now she's getting a progesterone deficiency, which is hair supportive, feel good hormone, progesterone, less anxiety, less worry, better sleep, and albeit she needs her endometrial tissue looked at, followed progressively, transvaginal ultrasounds. We need to look at her hormonal cascade as far as how she methylates and detoxifies so that her hormones are balanced. But progesterone is a lifesaver for her because it solves all her problems and it puts her in a less estrogen dominant effect, which is her risk and her worries about ovarian cancer, breast cancer, endometrial, uterine cancer. We got to get her out of this imbalance of hormones, which is for her estrogen dominance. Now, will she need estrogen? Absolutely. Once we appreciate her lining in her endometrium and the safety and how her hormones detoxify in her body, because we do everything very personalized, okay? We will create a balance of hormones for her, but progesterone is going to solve her issues, keep her balanced, lessen anxiety, okay, and reduce her risk of her concerns, cancer, okay? Now, when I say hormones, I'm talking about bioidentical, natural, personalized doses that we look at her in saliva and urine to make sure she detoxifies and methylates these hormones so they're used in her body appropriately, but that she eliminates them like she should. So thus we reduce risk, but create the best preventative and wellness model for her, okay? Not going to be that difficult, but I'm going to educate her and show her the evidence, because we do everything here, evidence-based medicine. We're going to show her the evidence of where things sit and fit for her, okay, so that she's happy and comfortable with the plan, okay? But when we talk about hormone replacement, and you hear me preach this passionately, we're not talking about synthetics. We're not talking about unopposed estrogen. We're not talking about progestins that, yes, cause breast cancer, okay? And we're talking about a personalized approach, okay? So when you look at old studies, you have to be wise about these. Old studies I agree with, the Women's Health Initiative, there are increased risks of breast cancer and other forms of cancer, okay? But those are a non-personalized approach to medicine, but to hormone replacement, which we don't endorse. Second case, okay? There's a saying I have, you can win the battle, but lose the war. This poor 67-year-old female, who's very thin to begin with, she's an ex-marathon runner, big runner enthusiast, was running literally out of the country in races a year ago at 66. Her developing this lung cancer and her developing this infection in her lung, and then now because of the damage to her lungs, okay, this oxygen deficiency, so she's oxygen dependent. She's getting into a wasting syndrome. Now, she has been very reluctant to do any hormone replacement with me. We do a lot of natural buildup of her immunity, working with her oncologist and her infectious disease doctor to build immunity, to build building blocks for her foundation. But one big missing piece for her, and I'm going to continue to encourage her to really reevaluate this, is we don't want to win the battle in this infection and this cancer, but lose the war, which could be her life. Because the biggest risk we have with aging is sarcopenia and wasting. You will not have not only quality of life, but you will not exist when things atrophy, harden, dry up, and die, and you cannot have a sustainable life with sarcopenia, which is muscle and bone wasting, osteoporosis, which she has, muscle wasting and weight loss, anorexia, okay? Hormones are building blocks for structure, muscle, your heart's a muscle, tissue, tendon, ligament, bone, okay? But keeping mass, all studies show this. When we lose mass, we actually get poor immunity, we age faster, our telomeres and genetics, our DNA damage and die earlier, okay? And you need to actually look at the building blocks that create a good foundational system when you're talking about, even in a poor case like this. I shouldn't say poor, I mean this patient, actually we are really heartfelt in doing our diligence, but really she's reluctant on the hormones because of age and she hasn't needed them before, and etc. But they're going to be a very key. Testosterone, estrogen, and progesterone and DHEA are going to be a very key building blocks to create weight in her. She can't waste away anymore. She gets down into the 80s pounds, she's going to be in the hospital on a peg tube, feeding her. I don't mean to sound, harsh or scary or drastic, but she is going to be very ill, and the cancer or the oxygen or the infection are not going to kill her. It's going to be a wasting syndrome that's going to kill her. And that is super sad, okay? Because that can be alleviated, or we can at least help potentiate any other therapeutics for her if we use a building block like hormone replacement, okay? The third case, this new patient, is interesting because I see this often. There's an article that just came out that I'm actually reproducing a review on in our winter newsletter soon about a similar case like this. But remember, I said this 47-year-old new patient that actually was in new menopause, and her goal or her symptoms or her issue is fatigue and pain. She had a degenerative back and a disc fusion in her back. She's had 6 epidurals. Well, corticosteroids, okay, yes, they're used appropriately at times for pain management and inflammation. But understand something, that they damage structure, okay? She already has structural back damage. They damage bone, they damage cartilage, they damage tissue, okay? They reduce immunity, okay? And yes, temporarily they give you pain relief and reduce inflammation, but the reality is long-term, and this is what this study that just came out, and was a reproducible study from about 7 years prior, okay, and it's going to be in our new newsletter, our new newsletter in a month, in this for this winter, is that long-term they show within 7 years, every patient report is negative when we're using corticosteroids, especially repetitively. She's had 6 epidurals. We're going to find that she has a very depleted adrenal system from shutting down her own adrenals, which are her own cortisol, her own kind of body steroid, her own anti-inflammatory. And I believe what it's going to show is that it's causing her to be fatigued, and she reports for years. It's causing her to have return of inflammation and back pain, because once your own cortisol system, your own adrenal system is shut down, okay, you can't produce your own adrenal cortisol response, so you're going to be very inflamed in general. Inflammation goes to areas of damage. She has a bad back, it's damaged. They want to potentially even do another surgery. She's very reluctant to do anything else because it's not worked out for her. But her fix is going to be regenerating her adrenal gland and supporting her adrenal gland, excuse me, in recovery and keeping her out of the cycle of epidurals, back surgery, etc. Okay? Because structurally, okay, you have to stabilize the spine, and good surgeons do this, and we have many we refer to, okay? And they're excellent with their hands and have the best intention. But to be on that hamster wheel of repetitive surgeries, I'm telling you, it's never a good outcome. Repetitive epidurals are never a good outcome. So we're going to find that she has low cortisol, low adrenal function, hypoadrenalism. We're going to have to support that and build her adrenals up. And then we're going to also have to support, because she's newly menopausal, what's going on with her sex hormones. Because testosterone is an anti-inflammatory hormone. It's a building block hormone. It can help her with pain. It helps pain. It can help with inflammation. And it can help solidify with estrogen and rebuild bone structure, because she's going to be at risk because of the corticosteroid and epidural use and her menopause for early osteoporosis. And mind you, she's 47 and reports herself that she has bad quality of life. So we got to get her off this pattern, okay, and get her on a new pattern, okay, that's going to build foundational systems in her, which hormones in the foundational systems approach in a personalized way that we do here at Longevity helps patients achieve their goals, but also us achieve wellness and prevention. So sorry today if I was long-winded, maybe a little excessively passionate. Didn't mean to be too demonstrative, and but these are common cases that we'll see here daily in our office, in our practices, that we help patients with very efficiently, very effectively, because we look at systems in your body that physiologically you can't ignore. Now, everything has to be looked at root cause, and that's what we do. So even in these cases, we're not just going to throw them on hormones. We're going to look at genetics, consider that. What's their stress level? What's their mind body? How are they sleeping? What's their gut health? What's their diet? What's their nutrients? How they detoxify? What's structurally going on? Like even the patient with the back, what's structurally currently going on? But we have to also look at the sixth system, or one of the six systems is your hormonal balance. Every person, whether you're 20 or 80 or 90 or 30 or 50, anything in between, male or female, you have to appreciate and evaluate your hormonal foundation to be well. So hopefully this wasn't too winded and long for you. Hopefully it educated you a bit and opened your mind to approaches with hormone replacement appropriately in a personalized way to keep you well. This is Dr. Lewerenz, Longevity Health Institute. Find us on the web. Please subscribe and follow us. Share with others. We're constantly bringing you advanced, personalized, evidence-based medicine. Be well.